So we have had very good trials going forward, like the Pioneer Heart Failure trial and the Transition trial, which have given a good insights. And they have shown that once your patient with acute decompensated heart failure is stable, and then at least he is in hospital for another 12 hours without any inotropes, without any inodilators, without any vasodilators, he is not having a fall in blood pressure. You do not want to increase his diuretic dose in the last 6 to 12 hours. So it means the patient is now hemodynamically stable, is yet not discharged, and that is perhaps the best time to start a ARNI. And these trials have shown that those patients who were put on ARNI pre-discharge or very early in the discharge, in the first follow-ups, those were the patients who did very well, and their decrease in the NT-proBNP levels was much higher. They had a very good discharge post period, and they did not require mostly further hospitalizations, and their improvement in quality of life was much more. So pre-discharge, I would say, is a better time in most of the patients. Some patients you have to take a call looking at clinically, but the points we have discussed, if all these points are fulfilled, then you can definitely start ARNI as early as even before discharging the patients. So this was the study we are talking about, that is the Pioneer Heart Failure study. They gave ARNI to patients who were stabilized, that is they were having systolic blood pressure of more than 100. So these are the precautions we should keep in mind. Systolic blood pressure of more than 100 prior to 6 hours, no symptomatic decrease in blood pressure, no increase needed in IV diuretics at least for 6 hours, and the patient is not on IV vasodilators and not on IV inotropes for 24 hours and not on IV vasodilators for the prior 6 hours, then you can definitely add ARNI before discharge. And this was a comparison of adding ARNI and enalapril, and it showed benefits in favor of sacubitril, valsartan, or ARNI. We can see the change in baseline NT-proBNP levels and the CV deaths or hospitalization on heart failure patient 8 weeks after starting. So pre-discharge is definitely one time when we should look at adding ARNI. So this is the breakdown of patient enrollments, and we can see in across the spectrum, whether it is de novo heart failure, also the benefits of ARNI as compared to enalapril are there. So these are patients who are not previously exposed to ACE or ARBs, but they also do very well on ARNI when started at first. So such improvements, even a statement has been made by the ACC in 2021 that these kind of improvements which we are experiencing with ARNI, it would be lost in the scenario of ACE or ARB pre-treatment. So if we give them ACE or ARB, this kind of benefits the patients will not achieve. So this is the outcomes of the Pioneer Heart Failure trial again, changes in the NT-proBNP and CV hospitalization deaths. So we are pretty much clear that we can, in most of our patients, before discharge also we can start ARNI, and it will give a long-term benefit to our patients.